This week's information will be on polycystic ovarian syndrome and common gynecological pelvic disorders. So infertility is caused by ovulatory dysfunction, uterine factors, and/or tubular peritoneal factors. There are multiple definitions this chapter, and a few of them are included here. Those include infrequent ovulation or oligo-ovulation, as well as lack of ovulation, termed ano-ovulation. Polycystic ovarian syndrome, also known as PCOS, occurs with women who frequently are oligomenic, hirsuate, obese, and infertile. The components include hyperandrogenism, oligoovulation, or ano-ovulation. It may include hirsutism, hair on the face, acne, acanthosis nigricans, or acrocrodons, which is a significant skin tag population. Polycystic ovaries, and those would be determined via ultrasound. The prevalence of polycystic ovarian syndrome is 4 to 10%. Studies show that 50 to 70% of women with PCOS have some level of insulin resistance. They are also at an increased risk of metabolic syndrome, which is a triad of abdominal obesity, hypercholesteremia or dyslipidemia, hypertension, and insulin resistance. In this population, weight loss should be encouraged to diminish some symptoms. When you're dealing with polycystic ovarian syndrome, some of the objective findings would be to do a complete physical exam on the patient, to assess face, chin, and abdomen for male pattern hair, as well as increased muscle mass, decreased breast tissue, and voice changes. Diagnostic testing includes an FSH at low or normal. Luteinizing hormone would be elevated. Luteinizing hormone FSH ratio would be greater than 3. Testosterone would be free, and the normal is 100 to 200. DHEA would be normal is 80 to 350 micrograms per milliliter, and normal ranges may decrease with age. There's also a 17-hydroxyprogesterone or 17-OHP, which screens for androgen excess due to polycystic ovarian syndrome, enzyme deficiency, or congenital adrenal hyperplasias. The normal in the luteal phase is 35 to 290, and a significant elevation suggests adrenal hyperplasia. You could also see dexamethasone suppression, and dexamethasone is a medication. 1 milligram is given orally at 11 p.m., and then a plasma cholesterol would be measured at 8 a.m. And if it's suppressed or less than 5 micrograms per mLs, you would then be able to rule out Cushing's. Corticotropin stimulation test is ACTH testing. Again, that would be done at 8 a.m. An intravenous bolus of synthetic ACTH would be administered, and then blood samples and cortisol are obtained prior to the bolus and then at 60-minute intervals to determine levels. You could also have a 3-hour glucose tolerance test, and then fasting insulin, as well as BUN and creatinine testing. There's multiple differential medical diagnoses for polycystic ovarian syndrome. Those would include ovarian disorders, adrenal disorders like congenital adrenal hyperplasia, androgen-producing tumors, Cushing's disease, drug-related changes, obesity, postmenopausal changes, incomplete testicular feminization, or idiopathic conditions. So with polycystic ovarian syndrome, the plan would be for weight loss, and you would counsel on improving nutrition, an exercise routine, that can cause a major change in lifestyle. You would also want to refer to endocrinology. Take into account psychosocial interventions, including anticipatory guidance regarding treatment and medication. And you want to offer the client support and referral to a psychologist and refer to a weight loss program or dietitian. You also want to review the risks of endometrial cancer, secondary to endometrial hyperplasia, and then metformin or glucophage. That is an anti-hyperglycemic drug that improves tissue sensitivity to insulin while decreasing insulin levels and inhibiting glucose production. When used in patients with PCOS, metformin reduces the luteinizing hormone, sex hormone binding globulin, and ovarian androgens and corrects hyperinsulinemia. Endometriosis is another common benign disorder. It causes chronic pain. We're now moving on to chapter 16. And it can also lead to infertility. It is the third leading cause of gynecological hospitalizations, and the extent of pain is influenced by the location and depth of the endometriotic implant. Endometriosis is more likely to occur in women who have menarche before 11, and also women who exercise 4 hours a week are less likely to develop endometriosis. Diet may play a role with consumption of animal fat and trans fat. There is an association of an increased risk of laparoscopically confirmed endometriosis, whereas a greater long-term intake of long-chain omega-3 fatty acid is associated with a decreased risk of laparoscopically diagnosed endometriosis. There is also a 7 to 10-fold increase in those with a first-degree relative affected with endometriosis. So what would you see with endometriosis as far as subjective? Subjectively, you would see the patient would complain of dysmenorrhea, chronic pelvic pain, dyspareunia or painful sex, as well as sacral backache during menses. On physical exam, patients should have a pelvic exam to determine the focal pain or tenderness, as well as diagnostic testing. In the book, they talk about ultrasonography as well as MRI and CT, and ultrasonography is the preferred diagnostic testing. They also discuss CA-125, which is a lab assay, and this is a diagnostic marker for endometriosis. However, the test is not recommended for diagnostic purposes because it does have a poor sensitivity and specificity. As far as other testing, diagnostic laparoscopy is the chosen testing per surgeons. It is a definitive method to diagnose and stage endometriosis. And some of the findings that you will see are classic endometriotic lesions. They are powder burn lesion or endometrioma, which resembles that of a chocolate cyst. So when you're dealing with endometriosis, you have to take into account the psychosocial interventions, the impact of the disease on life. That could also lead to assessing the patient for depression, which can be initiated or worsened by chronic pain. You also want to be aware of diet modifications that can help the patient in pain control, and then medications to control the pain and reduce pain. Those would include progestins, danazol, combined oral contraceptives, and NSAIDs. And NSAIDs are a common first-line treatment for endometriosis. That's because they have less side effects and work to reduce the pain in women. On to adnexal masses or ovarian tumors. This information is going over the classes of adnexal masses. So what are adnexal masses? They are enlarged structures within the uterine adnexa. They fall into these different categories. There's benign adnexal masses, which are functional cysts, particularly follicular corpus luteum, endometrioma, tubo-ovarian abscesses, or hydrosalpinx. There's also benign cystic masses, which fall into the category of dermoid cysts, serous and mucinous cyst adenomas. There are also benign solid masses, in particular fibrothecomas, adenofibromas, and Brenner tumors. Malignant ovarian tumors include serous and mucinous tumors, endometrioid carcinoma or clear cell carcinomas, granulosa cell tumors, germ cell tumors, and Sertoli-Leydig cell tumors. It's important to understand that in ovarian tumors, adnexal masses, these present in women of any age. The majority occur in reproductive age and tend to be functional and then spontaneously resolve. The malignancy factor does rise with the age of onset of the ovarian tumor. So if you have a patient that comes in with an adnexal tumor, the workup would include a urine pregnancy,